Hello all, I am Dr. Walter from SNS College of Physiotherapy. Now we are going for a next video, that is the differentiation between the UMN and the LMN. So what is the UMN and the LMN? We are going to see about in the categories and which and all categories will provoke, which will diminish. All these things which we are going to see in this video. So be updated on this video. Now upper motor neuron lesion and the lower motor neuron lesion. Actually, upper motor neuron lesion will be encountering with the brain to the spinal cord. These area, if they are getting any type of disease or any type of injury, will refer for the upper motor neuron lesion. Now going for the lower motor neuron lesion, will be going for the spinal cord to the muscles. Area which is away or which is out from the brain surface or out from the spinal cord surface will be considered as the lower motor neuron. Okay, so if any happening like any disease or any injury happening in this area will be referring as the LMN lesion. Okay, now entering inside the things of the science. Okay, how we can define and differentiate. Now, based on the muscle tone, upper motor neuron lesion will have the spasticity. Absolutely, we can able to see in the cerebral palsy cases and all, spasticity is more common. Yes. So, and associated with any other injuries will be having the spasticity in the UMN lesion. What will be happening in the LMN? LMN will be going for the flaccidity, that is the loss of the muscle tone. Spasticity high, it is rigid. Okay, based on the rigidity we are having certain types. Yes, lead pipe, cork wheel. So these are the types which we can see in the Parkinson's types of rigidity. And flaccidity also will be going for the muscle complete of the loss of the muscle tone. Now going for the next one is the reflexes. Okay, so what is reflex? When we stimulate or when we pinch or do anything, it will give a reflex action. Okay, so based on the Newton's law of reaction, this condition and this topic will be working out. How it will work out? In UMN, hyperreflexia, deep tendon reflexes will be exaggregated. Babinski sign is positive. Yes, what is Babinski sign? When we take a backside of the knee hammer, we'll be having a sharp needle, or else we can take our pen or anything, and we need to palpate onto the forefoot, and this will create the Babinski sign. And we need to differentiate what is the UMN and the LMN based on this reflexes, and we can able to easily find out, because hyperreflexia, and in LMN we'll be having a hyporeflexia and the absent of the reflex. Reflex will be mild or absent, and the Babinski sign will be going for the negative. Okay, so these are the differentiations which we can able to easily understand the reflexes in this UMN and the LMN. Now going for the next one, that is the muscle bulk. Absolutely, before entering into any type of accidents or disaster or any other encountering with the diseases, the muscle bulk of the person will be very good. Exactly, the patients will have take the enrich of the nutrients, and they will take the daily to day life of nutrients and proteins, and all these things will maintain their muscle bulk. After encountering with UMN or LMN, the muscle bulk will go for the differentiation, and based on the muscle bulk we can define what is UMN and what is LMN. UMN, no early wasting. Absolutely, it will go for wasting, but in the initial stages the wasting will be very less. If this going for the chronic stage and the prognosis is not going good, the wasting will develop, and it will also go for the severe wasting. But initial stages, UMN lesion will be having the no early wasting. But comparatively for going for the LMN, severe wasting at the early stage is most common. Okay, the muscle bulk, exactly where can we check these things? Biceps area, triceps area, calf muscle, and the quads and the hamstring. These are the major areas which we can able to physically and find out on the visible stages of the muscle bulk wasting. Now going for the last stage, the paralysis. UMN paralysis will be going for the spastic paralysis or group muscle paralysis. Group of muscle will be going for the paralysis. And in the physiotherapeutic field, when we are going to treat or stimulate, we need to keep in mind on which lesion is this going, either the UMN or the LMN. What will be having in the LMN? A flaccid paralysis, a individual muscle paralysis, or the individual muscle will be going for the degeneration. So we need to keep in mind on which area we need to give the treatment, on which muscle we need to stimulate. So group muscle stimulation is very worth in the UMN, but it is not so important or it is not so needed in the LMN. Now going for the conditions, UMN will be having the stroke, spinal cord injury, most important injuries in the day-to-day life. Okay, so which we have seen in the previous video about the fracture. So fractures based on the other parts of the body, that is the bones. This spinal cord injury, spinal cord fractures are more dangerous, and will be leading for the major fatal effects. Going for the LMN, will be having the peripheral nerve injury, for examples, radial nerve injury, the wrist drop, ulnar nerve injury, the median nerve injury, the peroneal nerve injury going for the foot drop, and these are the peripheral nerve injuries associated with the peripheral neuropathy, diabetic neuropathy. Okay, so in the chronic stage of the diabetes, it will develop into the peripheral diabetic neuropathy, which will lead to the excess of the condition and also the accumulation of the GBS, Guillain-Barré syndrome. So all these things which we can able to easily differentiate the UMN and the LMN lesion. So hope you have understood the differentiation in a very good manner. We'll see in the next video with a new topic. Thank you.